This video will be on pregnancy induced hypertension part 1, and it was in reference with the question that was asked in DNB 2025 part paper 1. The question was, a 24-year-old primary gravida presenting at 24 weeks of gestation with the BP of 160 by 100 and pedal edema. Now describe the investigative workup and management of the case. Next part is about the role of various screening tests for preeclampsia in early pregnancy and the indications of low dose aspirin in early pregnancy. So first of all, coming to the definition, the definition is according to ACOG, when the systolic blood pressure, when the blood pressure of the patient is more than 140 by 90 on 2 occasions 4 hours apart, and the BP is more than 160 by 110 of millimeters of mercury, and it remains the same even after 15 minutes, and the BP returns to normal by 12 weeks postpartum, then this is preeclampsia. The incidence of preeclampsia is 10.3%, while there is incidence of 3% eclampsia also. Now, how will you measure the blood pressure? The blood pressure can be measured by palpatory method or the auscultatory method. Palpatory method is when the BP is measured through pulse, means BP at which pulse is not palpable. So this blood pressure where BP is measured is systolic blood pressure. Auscultatory method measures both systolic and diastolic blood pressure. Initial inflation of the cuff 20 to 30 millimeters of mercury above the palpable systolic blood pressure. Then we have to deflate the cuff, and when the Korsakoff sound 1 appears, this is systolic blood pressure. On further deflation at a rate of 2 millimeters of mercury per second, diastolic blood pressure indicated by Korsakoff sound 5 is measured, and this is at the disappearance of the sound. If there is muffling of heart sound in males and non-pregnant females, then this is diastolic blood pressure. The cuff is deflated too fast, then there is underestimation of the BP or overestimation of the BP. Automated devices can measure BP, but may not measure BP in obese females and with irregular pulse. Now, what is mean arterial pressure? Mean arterial pressure is very important, and this is equals to the diastolic blood pressure plus 1/3 of pulse pressure, and the normal mean arterial pressure is around 85 to 104 millimeters of mercury. Now, why we are using Korsakoff sound 5, not Korsakoff sound 4 in pregnancy? Because Korsakoff sound 5 is more reflective of intra-arterial pressure, it is more reproducible and has less inter and intra-observer variations. Now, BP should be recorded nearest 2 millimeters of mercury. There is no rounding off of BP, and it should be measured in relaxed temperate settings. Patient should be quiet and should not have consumed tea or coffee and exercised or smoked in the last 30 minutes. The arms should be outstretched and supported. Patient should be in sitting position, and this is the best position, and if not sitting, then semi-recumbent position with slight left lateral tilt will be good. BP should not be measured in supine position because it can lead to supine hypertension syndrome, because the gravid uterus will press against the inferior vena cava and there will be decreased venous return, which in turn decreases the cardiac output, and hence there will be low BP. The cuff should be tied at the level of the heart. The correct cuff size is measured with 1.5 times of the arm circumference, and the standard cuff size is suitable for females with mid-arm circumference of less than 32 centimeter, and if there are obese females and the arm circumference is more, that is more than 32 centimeters, then pregnancy specific cuff should be used, and it should be 1.5 this arm circumference of such pregnant obese females. If we measure the BP through these standard cuffs, then BP is overestimated. Normal arm circumference with large cuff size, BP is underestimated. Now, there are 3 types of hypertensive disorders. We have divided the hypertensive disorders into 3 types. First one is the gestational hypertension, then we have chronic hypertension, then we have preeclampsia. Preeclampsia is divided into non-severe and severe preeclampsia. 10% of all pregnancies are complicated by hypertensive disorders, and it is a part of a deadly triad which contributes to maternal mortality and morbidity. The maximum, this is HIH, that is hemorrhage, which includes APH, PPH, I for infection, that is sepsis, and the last is hypertension. Now, according to ACOG 2020, hypertension in pregnancy is divided into four types: gestational hypertension, preeclampsia syndrome, chronic hypertension, and preeclampsia superimposed on chronic hypertension. Now, proteinuria is the excretion of protein in urine, and it can be used as a screening or a diagnostic test. For a screening, we use the urine dipstick method, in which if dipstick is more than 1 according to Williams and RCOG, then it is significant proteinuria, while the ACOG and NICE guidelines say that the dipstick of more than 2 plus urine dipstick protein is positive. So this is different, and we use NICE guidelines, and that's why we prefer 2 plus dipstick as a significant screening test. Now, coming to the diagnostic test means 24 hours urine protein excretion should be more than 0.3 grams, or the random urine protein excretion is more than 30 milligrams. Urine PCR is protein to creatinine ratio more than 0.3 is significant, or 30 milligrams per millimole. Or urine albumin creatinine ratio, that is urine ACR, is more than 8. So urine PCR is more than 0.3 and urine ACR is more than 8. We do not use morning urine sample to quantify proteinuria, and 24-hour urine protein excretion in pregnant females is not routinely done. Now, what are the signs of and organ damage according to ACOG 2020, and this is used in the diagnostic criteria of preeclampsia. If any of one of them is present, then these are the signs of end organ damage. So if platelet count is less than 1 lakh, then it is significant. Liver enzymes more than twice the normal value. Serum creatinine of 1.1. There are cerebral symptoms like headache, blurring of vision or dizziness, visual symptoms like diplopia, scotomas, blurring of vision is there, and pulmonary edema. So these 6 features if present, then these are the signs of end organ damage. And even if BP is 140 by 90 or more than that, but less than 160 by 110, and if these are signs of end organ damage is present, then the patient will be classified as severe preeclampsia. Now, what is a gestational hypertension? Gestational hypertension occurs in a previously normotensive female, means the BP is normal before pregnancy and the BP has increased after 20 weeks of pregnancy, but there is no proteinuria and no end organ damage. And all these criteria should be fulfilled to call it as a gestational hypertension. 50% of these females will progress to preeclampsia, that is either non-severe or the severe preeclampsia. We have to monitor the BP and check for the proteinuria and the signs of the end organ damage. So the BP is more than 140 by 90 but less than 160 by 110. There is no proteinuria, there is no sign of end organ damage, and the BP returns to normal within 12 weeks of pregnancy. Gestational hypertension with a BP of more than 160 by 110, even without proteinuria or signs of end organ damage, will be treated as severe preeclampsia. And if there is gestational hypertension which is severe, means BP is more than 160 by 110 and there is no proteinuria, then these 10% patients can progress to severe preeclampsia. Now, what is gestational hypertension? Gestational hypertension, that is after 12 weeks of delivery, in all patients with gestational hypertension, BP is measured. If the BP is normal, then this is classified as gestational hypertension or the transient hypertension of pregnancy. But if the BP is still high even after 12 weeks of delivery, then this is reclassified as chronic hypertension of pregnancy. So in a patient with gestational hypertension, BP should be measured after 12 weeks of pregnancy, and it is very necessary for its classification. Now, what is preeclampsia syndrome? Pregnancy specific syndrome which occurs affecting all the organs. It is characterized by increase in BP after 20 weeks of pregnancy along with any one of the following, that is either proteinuria, which is an objective marker of endothelial leak, and the signs of end organ damage as we have already discussed. Now, this preeclampsia syndrome is further classified into mild preeclampsia, also known as non-severe preeclampsia, or preeclampsia without severe features, and the severe preeclampsia. Preeclampsia without severe features means BP of more than 140 by 90 but less than 160 by 110, and there is proteinuria but there are no signs of the end organ damage. And if the BP is more than 160 by 110, there is no signs of end organ damage, then this is classified as severe preeclampsia. Now, based on the period of gestation, preeclampsia can be preterm preeclampsia, where the preeclampsia is occurring at less than 34 weeks of gestation. Early preterm preeclampsia means less than 34. Late onset preterm preeclampsia means 34 to 37 weeks. And the term preeclampsia, where the preeclampsia has occurred after 37 weeks of gestation. What is the sign? What are the signs of impending eclampsia? There is epigastric pain, visual disturbances like diplopia, scotomas, and blurring of vision, severe headache, which is not relieved by the usual medications. There are certain features which are not a part of the criteria of mild and severe preeclampsia, like urine output, degree of proteinuria, intrauterine growth restriction, and the worsening of edema. These are not criteria to differentiate between mild and severe preeclampsia. We have already looked for the ACOG 2020 guidelines, where proteinuria is at more than 2 plus on dipstick. Signs of end organ damage when the serum creatinine is more than 1.02 milligram per deciliter according to NICE guidelines, and 1.1 milligram per deciliter according to ACOG. Serum transaminase is more than twice the value, but if serum transaminase is if more than 40 international unit with or without right upper quadrant pain, this is according to NICE guidelines. Neurological complications like blindness, stroke, visual disturbances are included. Hematological complications like platelet count less than 1.5 lakh is according to NICE guidelines, and the platelet count less than 1 lakh according to ACOG 2020. Uteroplacental dysfunction is not included in ACOG guidelines, while it is included in NICE guidelines, which includes the fetal growth restriction, abnormal Dopplers, and the IUD. Now, what is chronic hypertension? If any one of the following is present, means the pregnant female is a known case of hypertension, increase in BP seen before 20 weeks of pregnancy, hypertension persists even after 12 weeks of delivery. No proteinuria or signs of end organ damage आर प्रेजेंट, मतलब पेशेंट को पहले से बीपी की दिक्कत थी, बीपी उसका 20 हफ्ते से पहले बढ़ा है और 12 हफ्ते के बाद भी नॉर्मलाइज नहीं हुआ है, एंड देर आर नो साइंस ऑफ एंड ऑर्गन डैमेज एंड प्रोटीन्यूरिया. ऑल दीज पेशेंट्स आर इंक्रीज रिस्क ऑफ डेवलपिंग सीवियर preeclampsia, and they can develop superimposed preeclampsia, and this condition is known as chronic hypertension with superimposed preeclampsia, in which the patient has elevated BP before 20 weeks of gestation, and the BP has suddenly increased at 20 weeks of gestation, become uncontrollable. There is new onset proteinuria and signs of end organ damage. In these females with chronic hypertension, preeclampsia develops at an early gestational age. It is more severe and is often accompanied by IUGR. So in these patients, we will start them on low dose aspirin. Now, what is eclampsia? Eclampsia is a condition in which patient had TTCS or generalized tonic-clonic seizures, also known as the grand mal seizures, which may be unifocal or multifocal. HELP syndrome is when there is severe preeclampsia with liver involvement and platelet consumption such that H for hemolysis occur, EL for elevated liver enzymes, and there is low platelet count also. All these three criteria should be present for diagnosis of HELP syndrome. Then we use two classification systems for HELP. First one is the Tennessee's criteria, in which there are three parameters just like the name HELP. So H for hemolysis, if any two of the following should be present, means 2 out of 4. That is, for hemolysis we have to do a peripheral blood smear where schistocytes, Bursell or the helmet cells are present as a sign of hemolysis. This hemolysis raises the bilirubin level and the total bilirubin is increased, but it is less than 5, and in total bilirubin, unconjugated bilirubin is raised more. We have to check the serum LDH, and the serum LDH, that is serum lactate dehydrogenase, which is released from the RBCs after hemolysis, is raised and is more than equal to 600 international unit per ml. There is decreased serum haptoglobin. Haptoglobin is a protein which binds to the hemoglobin. So if there is hemolysis, then hemoglobin will be dispersed within the plasma, and this hemoglobin binds to the haptoglobin. So the serum free haptoglobin levels are decreased and it is less than 25 milligrams per deciliter, and due to hemolysis patient is having severe anemia without any evident cause. So the first one is the peripheral blood smear, then we see for the bilirubin levels, LDH, and then severe anemia. Now, second is elevated liver enzymes, means AST, ALT are elevated more than twice their normal value, and the platelet count is less than 1 lakh. So if T for Tennessee, T for 2. So if 2 out of 4 are present, then this is a positive Tennessee's criteria. HELP syndrome complicates 5 to 20% of the preeclampsia cases, and 80 to 85% cases HELP syndrome में BP is elevated. So in rest 20% cases BP is not elevated. Even then the patient is having HELP syndrome. This HELP syndrome was first described by Weinstein. Then we have one classification known as Mississippi classification, and it is based on the severity of HELP syndrome, in which there is class 1 to class 3. Usually class 1 in rest of the classification system is considered as mild disease, but in Mississippi classification we consider class 1 as a severe disease, and we take parameters like the platelet count, ALT, AST, and the LDH. So if the platelet count is less than 50, AST, ALT is more than 70, means twice the normal value, and LDH is more than 600, this is severe HELP or class 1 HELP. And if the platelet count is 50,000 to 1 lakh, and rest parameters are same like class 1, then this is class 2. And if the platelet count is more than 1 lakh, that is 1 to 1.5 lakh, and the LFT is deranged but it is more than 40 international unit, not more than twice, then this is mild HELP syndrome. And the risk of bleeding in each of them is class 1 carries a bleeding risk of 13%, while rest does not or carry less risk. So the systolic blood pressure is determined by the cardiac output, while the diastolic blood pressure is calculated by the mean peripheral vascular resistance, and the MAP we have already discussed is diastolic blood pressure plus 1/3 of pulse pressure. Pulse pressure is calculated by subtracting systolic from the diastolic blood pressure from the systolic blood pressure. Now, what are the differential diagnoses of hypertension in pregnancy? So the BP can be raised due to certain disorders like a pheochromocytoma, in which patient is having raised BP along with other signs and symptoms like the panic attack, palpitations, tremors, generalized sweating, and increased blood glucose. And there is CKD. This is occurring due to CKD also, and it is more common in older females. Hyperthyroidism can also lead to hypertension in pregnancy, and in this condition there is raised BP with tachycardia. Hyperparathyroidism means hypertension with hypercalcemia. So these are the associations of hypertension in pregnancy. So the differential diagnosis could be pregnancy induced hypertension, pheochromocytoma, CKD, hyperthyroidism, and hyperparathyroidism.